Hello, Sanjay ji, I can see you.
My pleasure, but I can't see who made this remark.
It's Professor Singhal.
Oh.
Yeah, I'm just trying to find parking to join. I'm driving.
Good to see you. I was not expecting you, Professor Singhal, but very happy to see you.
Good to see you, sir. Good to see you. I thought I'll join for just to hear a few bits, and then I'm driving between the meetings as usual.
So we have got our diaspora supporting us from the UK and the US in this program.
President Dr. Gauri Sengupta has just asked for 5 minutes for joining in. Understandably so, because they are in the health ministry, so a lot of things are happening at their level. So he's requested for another 5 minutes.
No issue, no issue. We can wait.
So, President Sahab, kya haal hai aapke? How are you keeping?
Sub well, sir. I think we are all currently, I think, in a very relaxed state, but we are still all sitting in the fear of this dreaded third wave, which may or may not happen. That is the issue. That is the area of concern.
And also
I think
also the dreaded, and also the dreaded Delta Plus variant.
Delta Plus variant, Delta Plus. But point is the numbers are very, very low right now. I don't know, but it could spread very fast if that is the, if people are afraid, then there must be a reason to it, of course. So, Dr. Samir, what's your view on this, sir?
Now
we can see you, Dr. Parag.
Yeah, I can see. Yeah, so I'm in the car, as you can see. I'm driving. So no, I think this is what we are seeing, sir, is inevitable, because this is it is spreading. Until it continues to spread, mutations will take place, and there is a strong body of evidence now. If you look at, I was reading all the literature and everything, and I've been in touch with few top virologists who have been in touch with Wuhan. And they are convinced that it's a genetically engineered virus and it leaked accidentally. Therefore, this virus is not, the mutations are becoming more and more difficult and more dangerous. That's their view. And I think there is some, evidence to say that, because normal virus would have died by now, would have fizzled out. It is a problem. It is a problem.
Unfortunately, we can't choose other inhabitants of the planet, can we?
No.
We can't. Mount Everest, so I guess no place on earth is safe anymore, right?
We are joined by Dr. Subramanian as well, our chair for the Health Committee. Good evening, sir. Thank you for joining us. And we have the pleasure of having Dr. Prasoon Chatterjee, Associate Professor in the Department of Geriatric Medicine at AIIMS, New Delhi, and of course, the consultant for WHO Regional Office for Southeast Asia. Pleasure having you, Dr. Chatterjee. We're just waiting, as I said, for Dr. Gauri to join in, Dr. Gauri Sengupta from the Ministry of Health. She's asked for 5 minutes, about 2 minutes back, 2.5 minutes back, so she should be with us very soon. And we have a fantastic panel here, I think, from almost at least 3 continents of the country, of the world. We have Ms. Shalini Mathur all the way from US joining us in the wee hours with her coffee cup. And we have Professor Singhal all the way from UK, still driving between meetings and joining us. And of course, a lovely panel from India, and the great presence of our president, always there to encourage us, and our senior vice president, Mr. Pradeep Multani, to always keep pushing us to do better and much more than what we do. So we're just waiting for Dr. Gauri Sengupta ji. Please bear with us for a while.
UK, I believe, Dr. Singhal, the restrictions have been further extended.
You are on mute, Professor Singhal.
They were supposed to be lifted on 21st of June. So they have been extended for 3 to 4 weeks, but the likelihood is that by 15th of July, they will be lifted up. But the weddings are still going ahead. So what they have said is 30 plus number is allowed as long as there is social distancing. So that's good. So hospitality industry is very pleased that the weddings are
Summer
going ahead now.
solstice is the peak wedding season, I believe, in the Western countries, right?
Sorry, say it again.
I said summer solstice is the peak period for weddings in the.
It is. It's chock-a-block. All wedding venues are just chock-a-block. Absolute chock-a-block. Yeah, correct. So, yeah. Absolutely.
I think a lot depends upon also how the Delta Plus variant is out.
Yeah,
True.
it does.
Delta plus, how it pans out.
Yeah, how it pans out.
But is there any serious indication as of now that this is going to spread much faster than the other variants?
Well, we don't know. It's early days. But Delta variant, the UK data is now suggesting that 25% vaccine escape is happening with both doses, after both doses. That's worrying. But we don't have much data on the mortality side at the moment. But yes, people, despite 2 doses, are getting affected, and 25% of those hospital admissions are vaccine escape. So that's a bit worrying.
Yeah, I always wonder when the escape happens, that's after one exposure. With the second exposure, also does the risk remain 25% with repeated exposure? At some point or the other, in the Russian roulette, one day it'll get spread. But these are all speculations, right?
Yeah.
So maybe if we have some video presentation or something by on the subject, maybe we could start with that presentation in the meanwhile.
Right, President. We can do that. Dr. Grewal, would you like to do the honors? Dr. Grewal, are you able to share your screen, or shall we start your presentation if you say so?
Sorry, I was just speaking to somebody else. Yeah, you want me to start, please?
Yeah, that would be nice. As the President suggested, we could utilize this time for going through your presentation till such time Dr. Sen Gupta arrives.
Okay. I'll just share mine.
That would be nice. I hope you are able to share the screen. If you have any problems, do let us know. Otherwise, we can ask Ravi to share it, I think. Okay, great. We can see your screen share.
मच हो ये बिल्कुल ठीक है ये आगे करो ये बात नहीं इधर
Can I start, please?
बस ठीक
Please,
Yes, yes,
please,
please,
Dr. Gerwal, thank you so much. Please go ahead.
Good afternoon, everybody.
नहीं
Greetings to my dear friend, Dr. Subramaniam, the chair of the Health Committee, Mr. Sanjay Agrawal, the president of PHDCCI, Dr. Sengupta, Dr. Sameer, Shalini Mathur, the other Prasan Chatterjee, the other office bearers of PHDCCI. It's a pleasure to be here, and thank you very much for inviting me on a topic which is quite close to my heart and passionate about it. Well, the challenges faced by seniors in India, solutions and way ahead. When we talk about the challenges, the issues for today, which I see today, are seniors, challenges and solutions. Now, let's talk about the seniors first. Something is happening all over the world. Rapid urbanization and rapid aging. It's not just here, it's all over the world. It's happening in a different proportion in India, though. And India is an aging nation by the criteria of United Nations, which says that any country having a population of more than 7% who are above 60 is considered an aging nation. And India has crossed that number. So we are an aging nation. And within this rapid aging is the phenomenon of feminization and aging. It is evident from this chart. You'll see that the pink lines and the blue lines, the pinks are the females and the blue are the males. If you see from starting from below, as we grow, the pink lines start getting longer than the blue lines. This is at 70 to 74. And at 75, it's the pink lines are overtaking the blue. So what is this chart reflecting is that as people are growing in the elder population beyond 75, the number of females outgrow the males. Now this has consequences and challenges. And the consequences of females is longer periods of widowhood in Indians, social isolation, neglect, abuse, exploitation, violence, financial dependency, and most important, a hostile health system resulting in the lack of accessibility to timely, appropriate healthcare and support systems. So that's one of the consequences of a higher single lady population in India, which is called feminization in India. So therefore, India is going to be a grey nation much before it becomes a rich nation. Now, the challenges which come to my mind are ageism and self-care. Ageism, as defined way back in 1969, has three connected elements. Prejudicial attitudes towards older people, old age, and aging processes. So there's a prejudicial attitude towards older people, old age, and aging process. There are discriminatory practices against old people, and there are institutional practices and policies that perpetuate stereotypes about elderly people. This is defined in 1969 as ageism. And ageism is stereotyping and discrimination against individual or groups on the basis of their age. This may be casual or systematic. It is patterned on the lines of sexism and racism, which you may have heard before. In the 90s, I remember, and it was considered impossible for females to fly, females to drive. Now, what was happening is that you are stereotyping a person because of that person being a female and not because of the skill and the ability of the person. Exactly in the same way, when you stereotype olders, not because of their skill and ability, but because of their age, that is ageism. And this is used by the younger generation to give excuses of isolation and neglect of the elders. And that's a challenge. And the second one is self-care. Now, the self-care is what people themselves, the key word is themselves. So they themselves do to establish and maintain health and to prevent and deal with illness. Now, the word why I've underlined themselves, because self-care is a broad concept encompassing all these features: hygiene, nutrition, lifestyle, environment, socioeconomic, and self-medication. These all together form self-care. Self-care is not, as we say in Hindi, "मैं अपने आप को संभाल लूंगा." No, it's how good is a person able to maintain his own hygiene. So there's something that you got to do yourself. And for self-care, empowerment of the elder is essential. So unless you empower the elder, who has choices to make decisions on what he has to do with hygiene, what he has to eat. So if you deprive an elder person for his own choices or her choices, it is not self-care. And that amount, this type of behavior perpetuates chances of abuse. And that is a big challenge for elders today. So ladies and gentlemen, both these challenges of ageism and self-care cannot be met by the elders themselves. So we've been working on a model for quite some time, and we call it, we dedicate it to the nation, we call it the age-friendly pyramid. Now this is based on the global network of age-friendly cities, which isolated 8 social factors that affect the quality of life of elders. So what we are focusing is not longevity, but it is the quality of life of elders. It starts with stakeholders in age-friendly communities. So every stakeholder, he may be a banker, he may be a policeman, he may be an RWA, he may be a school principal, anybody and everybody needs to be sensitized and empowered to provide dignity to the elder for a quality of life. After you have sensitized the communities, then you start with the most important element which the elder faces is health services. So we need to start giving age-friendly primary health clinics and services. We need to have age-friendly neighborhood hospitals. We need to have an age-friendly secondary tertiary care hospitals. Once these 4 have been looked after, then we can have an age-friendly city and finally an age-friendly India. So that is the pyramid that we have made, and that is how we see is the solution to the challenge of ageism, abuse, and self-care. And unless we do this, we cannot try and achieve an age-friendly India. And only when we have an age-friendly India will the elders have a solution to their problems. Thank you very much.
Thank you very much, Dr. Geriwal. I think a very brief, very concise, to the point presentation with an excellent idea of building up a age-friendly pyramid. And I think it's something very, very interesting which you're doing, I think, back at the Fortis Escorts Hospital at Okla. Thank you very much, Dr. Geriwal. At this point of time, may I now welcome Dr. Gauri Ensign Gupta, the additional DG for the geriatric department for the geriatric care in Director General of Health Services Office of the Ministry of Health and Family Welfare. Thank you, ma'am, for joining us. It's a real pleasure to have you with us so that we can hear your thoughts and vision on the subject today. I know it's a tough task at your hand, considering the last 1.5 years of COVID, but nevertheless, we really thank you for taking out time for joining us this evening.
Thank you.
We took the liberty of utilizing that time for having this presentation from Dr. Geriwal, and we would kickstart the formal discussion and the program with a welcome address from Dr. N. Subramanian, who's the chair of the Health Committee of PhD Chamber of Commerce and Industry, as also the medical advisor for Indraprastha Apollo Hospital. Over to Dr. Subramanian.
Thank you, Mr. Sehgal. Namaste and a very good afternoon to all our esteemed panelists, our President Sanjay Agarwal, our President-elect Pradeep Multan, entire Secretariat for putting together such a wonderful program. We are all familiar that as people have continued to live longer, the quality of the life is something which has been addressed but not adequate. As Dr. Grewal so succinctly pointed out, the areas we need to focus on, we need to be quite conscious to the fact that the numbers of the elderly continue to rise. I mean, I remember the 70s when the concept of elderly was beginning to take shape in terms of both inpatient care in the hospital, the daycare units, the properly defined elderly home with the various areas. Because we have a lot of eminent speakers today, I wouldn't want to take much of your time. As somebody in a hospital-based care, what I tend to see and what we have visualized over the years, that number one, as people grow older, in addition to the common problems of diabetes and hypertension and heart disease and cancer, lung disease, there are other specific area-related challenges. There's a higher level of visual impairment. There is a higher level of hearing impairment. There's a higher level of dementia. There is a higher incidence of Alzheimer's. There is an increased incidence of delirium or confusions. In addition to common bone-related problems like osteoporosis. But all of these have two main things in common. One, it makes these people less capable of managing their activities of daily living. And secondly, it makes them more vulnerable in ways. The elderly, particularly with a visual or an auditory impairment, have a 7 times a higher risk of falling and having significant bony injuries. So I think we as a community and as a society are needing to create safer kind of millie, both at home and in the community for them to be able to live. And I mean live a meaningful life. Access to recreation centers, access to shopping areas, access to healthcare facilities, access to banks, anything. Today, I think the access of the elderly with any kind of limitation in mobility is so significantly limited. And even if they do manage to get into these areas, the safety factors are not adequately addressed. So I'm so glad that PhD Secretariat, with advice from our president, has chosen not only such an important topic, which is going to impact the lives of over 100 million people in the current context, and perhaps going forward in the next 2 decades, might be applicable to over 200 million people. So I think I must congratulate the entire team for putting this program together and for having such an outstanding faculty of esteemed specialists, both from India and abroad. So I'm just delighted to be part of this and would love to learn from this activities of this afternoon. And Bobby, personally, I must thank you for that wonderful presentation. Thank you.
Thank you. Thank you very much, Dr. Subramanian. 7 times you say, as you said, yes, 7 times it needs extra care for the aging population, considering their vision and other, problems, vision problems and other problems which may actually make it necessary. So very well put, Dr. Subramanian. Thank you very much. And I must inform our guest from the Ministry of Health and Family Welfare that, Madam, we are not only joined by our President and Senior Vice President because they found the importance of this topic as much to be here this evening, but we are also joined by two of our former presidents of the Chamber who are on the screen, and I like to welcome them with folded hands, Shri Binay Kumarji and Dr. Ashok Khanna, all the way from Chandigarh. So thank you very much, sirs, for joining us. It really adds to the grace of this particular program with your presence. We are also joined by Dr. Sonia Lal Gupta, who is the senior consultant neurologist from the Metro Group of Hospitals. Thank you very much, madam, for joining us. At this time, I'd like to invite our president, Mr. Sanjay Agarwal, to kindly deliver his presidential address. Over to you, sir.
Vivek ji, it's my pleasure and privilege to welcome on behalf of the PSD Chamber of Commerce and Industry our guest of honor today, Madam Dr. Gauri Sen Gupta, the Assistant Director General, Geriatric Health of Director General of Health Services. To have you join this program, and we know that you are extremely preoccupied at this time due to the current situation prevailing, but we are therefore really grateful that you found the topic important enough to welcome our other esteemed speakers in the session, Ms. Shalini Mathur from the Department of Elder Affairs, Government of Massachusetts, US. We really appreciate her getting up and so early and joining us for this program. Dr. Prasoon Chatterjee from the WHO Regional Office for Southeast Asia, the Department of Geriatric Medicine. The Editor-in-Chief of Voice of Elders.
Mr. President, we are losing your voice somewhere in the middle, sir.
Okay, let me check with my headphone. Is it better now?
Yes, sir.
Grewal, the Editor-in-Chief of Voice of Elders, Dr. Sonia Lal Gupta, Senior Neurologist Consultant from the Metro Group of Hospitals, Dr. O.P. Sharma, the General Secretary of Geriatric Society of India, and Mr. Sanjay, Senior and Assisted Living. Our own former presidents, Binay Kumarji and Ashok Khanna ji, we are privileged by your presence, sir. I'd also like to welcome Dr. Subramaniam, the chair of the Health Committee, Dr. Samir Gupta, Dr. Professor Harvinder Popli, and Professor Parag Singhal, the office bearers of our Health Committee who have taken this initiative to bring out this important subject, and of course, Mr. Vivek Sehgal, the Assistant Secretary General of the Chamber. Gentlemen, it's really a privilege and a pleasure for me to be a part of this webinar today. I'd like to give a brief background of the PSD Chamber for those who are not fully aware of about our chamber. The PSD Chamber has been working as a catalyst for the promotion of Indian industry, trade and entrepreneurship for the past 16 years. We are a forward-looking, proactive and dynamic pan-India apex organization. As a part of industry and government, the PSD Chamber, with a special focus on MSMEs, grassroots level, with these national and national linkages for and integrated development of the Indian economy. 1.5 lakh enterprises and businesses of various sizes, ranging from micro and small to some of the largest enterprises. Our country is surely witnessing a demographic shift as 60+ population continues to rise inexorably. In the 2011 census, the number for 60+ population stood at 100.
Mr. President, we are still losing you in part.
So let me try and see if I can.
does it sound better now?
Yes, Mr. President.
Oh, I'm surprised. Normally, one would have expected the headphones to work better. So, all right, okay. So, the country is witnessing a significant demographic shift in the 60+ population, as I mentioned, 103 million population. The number is expected to reach 319 million by 2050, which at just with a 3% growth, that's the power of compounding. But this number is going to be huge for any economy, any nation to handle. And yes, we need to be very well prepared for that condition and that possibility. So what is really important to understand from these numbers, of course, is that the signal of the aging tsunami lying ahead for the country, and that this may be, leading to a sharp increase in mortality and morbidity across the nation for the geriatrics, and therefore how well prepared we are to face these challenges, of course, I believe is going to be pretty crucial. Talking about the key challenges faced by the elderly population in accessing healthcare in India, first is the physical healthcare infrastructure, which is, of course, a major disadvantage, a major deterrent to ensure care for the elderly people. For example, in India, there are just a very few public ramps or purpose-built homes for older citizens who are unable to move. This is, of course, changing slowly. We are seeing the advent of many housing societies purpose-built for the elderly with certain facilities. But in general, the physical infrastructure is not friendly towards people with disabilities. And the elderly people, of course, are more or less going to be very prone to such disabilities. The second is the social barrier shaped by the various axes of social inequality, whether it's gender, religion, caste, socio-economic status, etc. Dr. Grewal also mentioned that this really amounts to discrimination in many ways in terms of age, and that by itself is also a big difficulty. The rising number of nuclear families presents another challenge for elder care management, because the isolation means that the elderly don't have the immediate family to look after them. Third is, of course, the little private or public financial support for the elderly in the country. The health cost is rising in old age, and there is very low penetration in the senior health insurance, which is also an extremely poor payout history. On top of that, the government budgets need a lot to be done. I think even doubling the current health expenditure as a percentage of GDP might be just be the beginning to really address the problems, because as it is very widely believed, the expenditure that you do on your basic social infrastructure, whether it is health or education or even sports, these are the things which have the biggest multiplier effect on the economy and the well-being of the society. So this is probably some sort of a realization which probably we need to have in a much greater sense in our country. The fourth, of course, is the knowledge about specific geriatric diseases, which requires continuous monitoring of the elderly population. And again, that is something that needs to be taken care of in a much more systematic manner than what we are seeing today. The infrastructure for the emergency response for elderly, again, is quite ill developed. So all these challenges are going to increase manifold as we see the increase in the population of the older people in our country. So I think there is definitely a lot that we need to do on this front. The country has not only to tackle the age-related psychological and physical ailment issues, but also has to gear up to promote rehabilitation and preventive care solutions in respect of senior care. With a rapidly growing elderly population, India is faced with Herculean task of providing basic senior-friendly urban infrastructure. The motive is to ensure affordable, accessible, and quality healthcare for all. India is a big country with a lot of diversity, and one solution cannot be fit for all. Some of the key solutions that we suggest are public-private partnership to promote not only physical but psychological health also to the elderly, to leverage the digital technology in senior care, which could be of much more relevance and help now that the acceptability of digital interaction between patients and doctors is becoming more and more acceptable after the pandemic. And then compulsory health insurance for all affordable and accessible life-saving medicines to successfully address the needs of our aging population, in addition to improving healthcare for all. I'm sure that today's webinar, with all the galaxy of such prominent experts present with us, is going to deliberate well on these important issues. And I think, and I really hope that we are going to come up with some very positive suggestions and solutions. And of course, we are all very anxious to hear Dr. Gauri Sengupta from the Ministry of Health and Family Welfare to guide us and give her vision, share her vision on geriatric care in India. I think you are the person actually at the helm of these affairs, and your views would be, I think, most important for all the stakeholders to be really aware of today. Thank you so much.
Thank you. Thank you very much, President. Indeed, for setting out the tone and, of course, highlighting the key points which we could touch upon apart from other inputs which would be coming from the specialists this evening. Thank you, President. Time for me to invite Dr. Gauri N. Sengupta, Assistant Director General for Geriatric Health, Directorate General of Health Services, that's DGHS, Ministry of Health and Family Welfare, Government of India. So I will not go beyond that introduction, ma'am. And I must tell the audience and the esteemed panelists, while I was in the process of inviting Dr. Sengupta, I could actually hear the passion which she has, apart from the responsibilities she carries for geriatric health. Over to you, ma'am.
Thank you, Vivek ji. Thank you, sir, for all those kind words. Uh, I've had a major glitch with a lot of light and all going away. So what the PPT that I had intended initially is not available with me, but still I'll try to put in what
Well, I think
prepared.
extempore will be more from your heart, so it will be much
No,
better.
no, the PPT is there, sir. Thank you so much. And I'm really honored that I got this invite. And it's always a pleasure to talk about geriatrics. Vivek ji has rightly pointed out that geriatrics is not just my charge which has been given by GOI. I've had the good fortune of taking care of two sets of geriatrics, both from my side as well as my in law side. So it's been a pleasure understanding, and God has given me this opportunity to operationalize certain things through a program which I think 5 years back nobody was aware of. And I will not be wrong in saying that, other than a few of our esteemed panelists who are already a part of the program, most of you will not be aware of even this particular program, which is being run in this country since 2010. So, without further ado, although my slides are quite a lot, I'll try and finish. I've timed myself for around 10 minutes. So, please do let me know in case I'm boring you. So, I'll just share my slides. Okay.
We can see your screen share.
Yeah. So, is that in slide share mode, sir?
Yeah, yeah.
Yes.
Okay. So once again, my although the topic was challenges being faced by seniors in the country, I would not like to call it just challenges. My perspective has been that there are opportunities. So what I am planning to do through this is four things to understand why elder care is required. Because 5 years back, when this program was given to me, and I used to go from one joint secretary to additional secretary to various forums. Dr. Prosun is there, Dr. Bobby is there, and they all know that I've been like literally hounding everybody. The first question everybody asks is, why do we need geriatrics, or for that matter, why is elder care so important? So that is my first objective, which I would like to put in through this particular presentation. The second thing is identifying the various challenges that were already there. So my task has been made quite easy to a certain extent by Dr. Grewal also, that few of things he has identified, but this is to identify a person-centered care. And thirdly, of course, being the spokesperson for the national program, I'd like to give a brief overview of what the program has achieved. And lastly, like I said, what is the opportunity that we have in elder care vis a vis the proclamation of 2020 to 2030 being declared by the UN as the decade of healthy aging? So, overall, there are just four things: that there is no typical elderly. I'm sure all of us have our own personal experiences also, that there is no such thing as a typical elderly. An 80-year-old could have the level of physical and mental capacity which is much better than 40-year-olds. My previous boss, I used to always say, at the age of 65, he could climb 5 set of stairs much faster than I could. And others of the same age may require extensive care and support, even for the basic activities of daily life, like dressing, eating, toileting, and all. Second most important thing is that every elderly is unique. I always say this, like in case of pediatrics, every child is unique. Similarly, every elder is unique, and what works for one may not work for the other. The third most important thing is that most of the time, whatever complaints, not only health issues, even other issues of elderly, are just brushed aside, saying that they are just as a part of normal aging, wear and tear. And fourthly, or the most important thing, we talk about elder care as if we are preaching to the elderly. But in a democratic country like ours, it is the elderly who need to take on the mantle of having informed choices and decision making capacity. So this has often been shown everywhere. So all we need to see is, right now, from approximately 89 to 10% of the population, we've already reached that 11.2% population. We are estimated to be doubling it to 20.6. And not only that, if you see the sex ratio, we are going to be having a feminization of the elderly population. And overall, the country is still stuck with maternal and child health, whereas elderly women specific programs are absolutely lacking. This is a just to give you a brief overview, just look at those red percentages. At every subgroup of 60 plus, 70 plus, and 80 plus, we are going to be going from 9.9% to 17.3%. 3.8% of 70 plus elderly are going to be increasing to 7.6%. And mind you, the last bit, that is 80 plus population, which requires most amount of care, specifically healthcare, is also going to be going from 0.8% to 1.8%. So there is no doubt about identifying the fact that yes, we are going to have a mammoth amount of elderly on our hands. And this is based on all data that what are the kind of services that are being required by all the elderly people based on whether they have one disease or two disease or three disease or elderly with multimorbidity. So all elderly require right from preventive and promotive care to assistive, rehabilitative, and long term care, which could be both home based care or it could also be critical care. Now, even the disability status among older people, it is claimed and it has been proven by the Lassie study that approximately around 45 to 55% of elderly are suffering from some or the other form of disability, not only impairment, it is inherent disability which has been diagnosed. And these are just a few kinds of rehabilitation services which they require, along with ophthalmological, physiotherapy, psychiatric services, and all others. Mind you, the list is endless. This is just to give you a brief overview of the different kind of disabilities which are prevalent and the care that is required. Now, overall, if you talk about the challenges of the aging population, as far as the health sector is concerned, I would say the double burden of disease that already suffering from non communicable diseases, elderly are also prone to having acute and debilitating illnesses. This has been amply proved by the first wave of COVID, which was specific to the elderly population. The increased risk of disability, which is not only due to the onset of chronic diseases, but also due to the normal aging wear and tear. Care for elders, like Sir had said earlier, the President Sir, that the biggest challenge that we face is in the balance between the informal support, which in India till today is the family, which could be immediate or extended family, and the formal support, the formal caregiving sector. Feminization of elderly is definite, and they are at a higher disadvantage of getting care services because firstly they have very poor healthcare seeking behavior, and secondly most of the elderly females are not adept at acquiring these services on their own. They are dependent on family members economically, physically, and emotionally. Ethics and inequities, age related discrimination in resource allocation is prevalent across the sectors. And lastly, the economy of elders is a questionable thing because of all sorts of inefficiencies. The cost of long term care demand has got immense expenses, whereas the elders have a very low income. So, if I specifically stick to the health sector, what we identified as the main challenges faced by the primary, secondary, and the tertiary level health sector is multimorbidity, because an elderly will have at least two or more morbidities prevalent. Along with that, they might have some acute illnesses also. So, conducting a comprehensive geriatric assessment and simultaneously managing all those morbidities is something which is a major challenge. Even today, every elderly is being addressed only for the particular symptom with which they present, whether it be at primary level, whether it be at secondary or at a tertiary care hospital also. The second most important thing, which is really alarming, is the polypharmacy which is practiced and which is inherent with elderly. This is not only within the allopathic system. If you note, any elderly will have minimum 5 tablets or pills which they will be having. It could be one for diabetes, one for hypertension, one vitamin supplement, one calcium supplement, and one painkiller. And because of that painkiller, if it is causing a gastritis, you will be given something to mask that gastritis also. So, minimum 5 drugs. And unfortunately, because of no regular visiting and no regular down modulation or down regulation of the prescription, we have elderly continuing with that particular drug profile for 5 to 6 drugs for months together. Not only that, along with allopathy, there could be other systems of medicines also which they are taking. So, at any point of time, it is impossible to find out without a comprehensive assessment whether whatever the person is suffering is because of a disease process or whether it is due to an adverse effect of some or the other medication. The third most important challenge is understanding the poor healthcare seeking behavior. This could be either due to accessibility, affordability, or even lack of awareness and mobility issues of the elderly per se. It is not possible just for the healthcare system, or for that matter even any system, whether it be government or private, to provide all sorts of services at the doorstep if the demand is not there. So it has to be a very good a mix between the demand and the supply generation. And lastly, the concept of healthy aging is something which is not very prevalent at all times to all elderly. What we, on an individual basis, on a medical basis, and even as a society, we are just trying to kind of address whatever health issues or socio-economic issues occur at that point of time. But nowhere are we promoting the concept of healthy aging, that is, maintaining the functional ability of every elderly, even if it is with the use of assistive devices. Elderly do not like using assistive devices, and somehow that is a gap which has never been tried to bridge. Maintaining the intrinsic capacity of the elderly, not only of an active body, but also of an active mind to counter cognitive decline. 60 plus or even 58 plus at some point of time, government and private sector retires you. And after that, you are left to fend for yourself, how to keep yourself active. Now, here the factor of urban and rural elderly also comes into play, with a very surprising fact that a rural elderly would be much more active and have lesser cognitive decline as compared to an urban elderly who has all resources at hand. So this is also something that we need to develop capacities for promoting healthy aging in all fora, not only just in the health concept. And other than the primary care level, at the secondary and tertiary care level, what we as a country lack is trained geriatric caregivers. I would say not only trained, that would be the new trained, but even the existing plethora of geriatric care providers. When I say that, I include right from medical or geriatrician specialists down to even a ward boy, or even an x-ray technician, or even a staff nurse, or even a rehabilitation therapist. So sensitizing them towards geriatric care is lacking across the sectors. And even now, elders are being treated by various medical specialists with no standardized specific trainings, specifically for certain sectors like rehabilitation therapists, home care providers, and even a few of the trainings or sensitizations which are available. they do not cater to all the sectors of both formal as well as informal caregivers. Now, coming to my second point of the national program, with that in mind, the national policy for older persons was formulated by the Ministry of Social Justice way back in 1999, whose goal was basically the well being of older persons. And its basic purpose is to let an elderly live the last phase of his life with purpose, dignity, and peace. And amongst the 14 areas of intervention, healthcare and nutrition was mandated to the Ministry of Health and Family Welfare, which, in compliance with the national policy as well as the UNCRPD regulation, developed this national program for healthcare of elderly to develop dedicated care services, create new architecture for aging, to build a framework for enabling environment which is a society for all ages, to promote the concept of active and healthy aging, and most important, where everybody comes in, is the convergence within the National Health Mission, the various departments, and other sectors. Now, the various strategies which are there in the program are service delivery. We have at primary healthcare level, we have at district hospitals, we have a 10-bedded ward with human resources, machinery, drugs, and all sorts of stuff. At 18 medical colleges of the country, we have identified regional geriatric centers to develop Department of Geriatrics, developing a very robust IEC network and plan of action, and of course, the monitoring and evaluation. And the expected outcome was that all these 18, 19 medical colleges will develop the Department of Geriatric, which will give out those trained manpower and be the kind of resources for that particular state. Other than that, we would have district geriatric units with a 10-bedded ward and OPD, physiotherapy, and all other services at all the 713 district hospitals across the country. And at the CHC, PHC, and the health and wellness center levels under the Ayushman Bharat, the OPD services and the rehabilitation services, right down to home-based care, to be delivered, and of course, developing trainings and sensitization. So these are the details of those services. This is already available on the site, and for anybody who is very much interested, you can go ahead and I'll give you a share the site also. These are all the details of each and every place where you have to have those specific kind of services. What I'd like to point out is that right from the health and wellness center level at the village, there is a mechanism or infrastructure developing in place up to the National Centers for Aging at AIIMS New Delhi and at Madras Medical College, Chennai. So the infrastructure, the system, the people, they're all there. What is required are the linkages that are to be created. Now, this I would like to say is my report card of the last 5 years. So we started with approximately 95 districts of the country, which was sanctioned. When I mean sanctioned, the states come to us with their proposals of what they'd like to do, and we sanction them funds and approve their activities, and then they go about and we monitor what they have done in the states. So from 95, I'm very proud to state that as of March this year, all the 718 district hospitals and other things in the country have been sanctioned, provided funds for developing geriatric care services. And of those, at least 584 have already reported that they have operationalized at least a separate geriatric OPD services. And amongst the tertiary component, we have approximately starting from 8 regional geriatric centers. We have around 19 regional geriatric centers sanctioned, of which at least 18 have started their services. And this is the further details of that as to who all have developed all these kinds of things. So at least I must say that we have been able to create around 5,000 beds in each and every district hospital. to provide this. And other than that, the 200 beds that were commissioned under the National Center for Aging at Madras Medical College, Chennai, has become fully functional and operational as a COVID care hospital. The government of Tamil Nadu is using it, but definitely it is a way ahead from what it was like at least 5 years back. So this is just to give you a brief overview of approximately 2 crore 65 lakh individuals, even provision, who have availed of the OPD care services, close to 10 lakh indoor admissions. And this is to give you an idea that even during COVID times, the states have really put in the efforts, and with the wave one being very detrimental for elderly, they have still been able to provide various kinds of services. All these kinds of services like drug distribution and all were provided at the doorstep in most of the states, through various agencies. Like Kerala provided it through Anganwadi workers, Karnataka and Tamil Nadu provided it through home based team of physiotherapists and staff nurses. Outside in the east, they harnessed the services of NSS volunteers and NYKS, Yuva Kendra Sangathan boys and girls, to provide medicines for 2 months for diabetes and hypertension and all to them. And we've had a number of experiences from the various states, elder lines being put up for not only medical care but also for psychological support. NIMHANS had come out with a specific line where they could call up, elderly could call up. The eSanjeevani portal was made functional where you could have teleconsultation. And a number of examples, like we had very good advisories coming out from the Ministry of Health as to what to do and what not to do. And we collaborated with the Ministry of Social Justice also through the AIMS New Delhi to develop advisories for even old age homes where they had a lack of resources as far as manpower and services and equipments were concerned. So this is the NPHC website for those who are not aware. You can go in. I think it has a security clearance issue, so you have to click whether, when Google asks you that this is objectionable site, you have to say yes, I still want to go and see it. So then you'll be able to see the this thing, all the resources that are being produced, even up to the guidelines, the training modules, the IEC, the photographs. Each state uploads their photographs as to what is it that they have done. Everything is available on this site. Now, this is one of the very beautiful fitness booklets which was developed during the COVID times and provided to each and every state. Every state got the soft copies. Along with that, they got around 10,000 copies of this in Hindi and in English based on their preference, which had everything right from communicable, non-communicable diseases. You had what to do, how to do yoga, how to do keep yourself fit during this time. And other than that, there were a lot of other IEC material which was developed for elderly care. So this is just to give you an overview. And I must congratulate my whole team, in which even Dr. Proshan was also a part of it, and others were also a part of it as the task force of the government of India. We have been able to develop a comprehensive geriatric care assessment and care training module for medical officers, for nurses, and for community health workers, which can be utilized. It's available for anybody who'd like to use it for conducting standardized trainings amongst all these cadre of workers. The biggest achievement, which I would say for elder care, was the commitment given by our Honorable HFM Shri Harshvardhan ji, who came out with a press release and a beautiful statement for the decade of healthy aging. And it was under his guidance that we were able to release the Lassi report, which everybody knows was long overdue for the last 3 years, on the 6th of January this year. And based on that, a lot of programs and a lot of perspectives change in the policies, and a lot of things have been identified to be conducted for the decade of healthy aging. This was the 1st October, and the whole of month of October to be celebrated by month of elderly. There were n number of things, but this is right across the country. So this is just because everywhere everybody likes seeing proof of what is going on. So this is proof of there is something going on, but unfortunately everything is in bits and pieces and not linked together much. Coming to the last portion of my talk, I'm aware I've already overshot my time, so I'm going to go slightly faster. The concept of healthy aging, which I would urge everyone to adopt, and it is not just the mandate of the health sector, it is the mandate of every individual, because even we are also going into that same age. So, healthy aging is the process of developing and maintaining the functional ability of a person that enables the well being in older age. And this is the concept which needs to be put in every policy, in every program, and in every initiative or strategy that we are building. Now, the trajectories of aging could be in various manners, but the three possible outcomes that could be there with health, at least while aging, is you could have a high and a stable capacity aged person, you could have a person with declining capacity, or you could have a person with significant loss of capacity. So, why do we need to act? Because every elder person has his own rights. So, it is their right to live healthy till they die. Aging is directly proportional to the health as well as to the development sector and to the development of health. And aging has got a lot of economic imperatives, which I am sure you are much more aware of, being in the consumer sectors and being in all the businesses across the country. And most importantly, which we forget, is that what are the things which are important to an older person? It is their role or their identity, the relationships that they have, the possibilities of enjoying autonomy, security, and most importantly, the potential for personal growth. Now, as far as the strategies for healthy aging are concerned, we have n amount of strategies, but I'd like to combine it into 5 most important. Firstly, committing to action. And I must congratulate the PHDCC that you have taken this commitment to act on this concept of identifying at least the challenges for seniors so that you can go ahead and work on it. So, establishing national frameworks for healthy aging, strengthening the capacities for formulating evidence based policy, and combating ageism. As far as the Ministry of Health is concerned, under the program, we have formulated under the Ayushman Bharat and the Atmanirbhar Bharat, the primary healthcare system, the age old classification of elderly, that 60 to 70 is young old, 70 to 80 is old, and 80 and above is oldest old. We are doing away with this particular age based classification. What we introduce is mobility based classification, that is, elderly who are mobile on their own. Second is those elderly who have restricted mobility and are able to move around only with the assistance of a person or some gadget. And lastly, a homebound or a bedbound elderly. So that is our commitment to combating ageism. The second most important thing is aligning not only health systems, but at least definitely health systems to the needs of the older people and to developing access to quality and standardized person centric care. So, for that, the comprehensive geriatric assessment, which was earlier available only at the tertiary care centers like the big hospitals and AIMS and MMC and all, we are trying to develop a comprehensive geriatric assessment of all elderly at the primary level at least once a year, preferably twice a year, from the PHC level and below. And developing age-friendly environment requires a lot of intersectoral coordination. But yes, definitely the recommendations are action and also uh, enabling or involving the elderly also. Strengthening the long term care is something which requires a very good intersectoral mechanism between the private sector, the government sector, because it is just not possible only for the government sector to look after the long term care. And we have a lot of beautiful examples in the private sector of delivering long term care, especially for COVID times, home based care settings, and earlier also amongst the assisted living centers, the dementia care centers, etc., which are there in the south and in the west. And improving measurement, monitoring, and research. This is something which we also need to work on, along with developing a workforce of elderly, developing the research capacities also to find out the best practices, pilot models, and escalate them at a national or at least at a regional level. So, for the decade of healthy aging, which UN has already identified, the government, civil society, international agencies, professionals, academia, media, private sectors require at least 10 years of concerted, catalytic, and collaborative action to improve the lives of older people. I do not need to tell you all about the relevance of this particular goal to the Sustainable Development Goals. And why we need this is because at 60 years of age, the expected lifespan is going to be at least 22 years. And the number of people we are going to be catering to is around 300 million. So there are a lot of opportunities where we can add years to life even while aging. So, like I said, we need to shift aging from challenges to opportunity. And the opportunities are abundant. uh, I wouldn't be wrong, or maybe I think I'll have a lot of my own colleagues also, which will who will agree with me that COVID has been a blessing in disguise for elderly. The focus that has been given to elderly, whether it be in identifying them as vulnerable population, providing specific services for them, the way different sectors of rural development, social welfare, health, and everybody came together and garnered all kinds of services from the private sector, the public sector, even now the elder line that has been launched for the elderly. So that's a very good example. And I think that is the biggest opportunity that we have at the onset of the decade of healthy aging, which we should harness for the benefit of elder care in the country. So, fostering healthy aging specifically through harnessing technology, scientific technology, medical, assistive technology, and most importantly, the digital initiatives that have come out in this particular time. It is, I think it was unthinkable about a year back to have this kind of a plethora of around 70, 80 individuals across the country, across various sectors, and even internationally coming together to debate that too through online facilities. So it's amazing, it's really amazing. And the areas for action are a lot. I'll skip them slightly because of paucity of time. What I would like to foster on everyone is the partnership that is required for change. Without a collaborative, multi sectoral partnering, without listening to diverse voices, without connecting to the various stakeholders, it is not possible for us to bring about a change in the mindset of elderly or change in the mindset of every individual towards elderly. Now, the level of preparedness, this is the country level preparedness, which I was preparing for reporting to the WHO. So I thought I might as well share it with you that we are already halfway across there. So out of 21, we've already got 13 marks. And I am sure by the end of this decade, we will have all 100% marks as far as the country level of preparedness is concerned. So I conclude by saying that population aging will continue and so will the consequences. If we are sluggish, it can lead to a disaster. If we are concerned, it can become an opportunity, but it all depends on how well we are prepared for it. Thank you so much.
Absolutely wonderful listening to you, ma'am. The amount of, I would say, the dedication and the depth of, work that is going on in your area of geriatric care, I think it's actually amazing. My only request would be, ma'am, we need to actually publicize it a bit more, or rather much more, so that the intended beneficiaries are fully aware of what all actually the government is doing, what all this NPHCE is all about.
Thank you.
Thank you, ma'am. Thank you.
Thank you very much, Dr. Sen Gupta. And I think it will be only appropriate for me to say that your passion reflected in your presentation, and also your commitment to something as important as geriatric care, which is, I think
passion is the word I would like to underline again.
Right, President. And in fact, I think that's compelled the panelists to, put in all kind of compliments into the chat box on, the depth and the coverage and the, passion again on the presentation.
She's the torch bearer of geriatric care in the government. She's the only one. One point contact.
One is enough, sir. One is enough. If the torch is borne properly.
Thank you.
But now I must say that now I need more torch bearers everywhere because government doesn't allow you to stay around more than 5 years in anything. So I think now I can easily share my burden with all of you, and I have a lot of other torch bearers everywhere across. Whether I'm there in the program or not, I will always be committed to geriatrics, and I must say that the program is just a drop in the ocean. Like I said, my earlier presentation had a lot of experiences which we've had with the private sector also. Like with Tata Trusts, we had very good examples of a collaborative effort for elder care in the state of Maharashtra, Telangana, and Karnataka, and at least we were able to facilitate it. There were a lot of opportunities for identifying like trainings, for that matter, like Sir said, the outreach, the publicity, and the availability, and more important than that, home based care, developing standardized protocols and conducting good quality research, and that too operational research, not the kind of research that remains in the journals. Identifying best practices and piloting those models in small areas. I think that doesn't require just the program or even the government of India or whatever. So I think private sector is abundant with beautiful examples. And over a period of 5 years, I've seen that the kind of quality that is being upholded at the private level has been very good. At the urban level, I would say that we need to again revisit, but still, I think it is very good examples of things are there. Like I already said, instead of identifying and harping on the challenges, I think it's about time we started propagating, or I would say, doing a propaganda of all that is being done, which is very good, identifying the best practices and really talking about them. There are beautiful examples in the field. So that would be my request to the PHDCC to take it forward. And I'm anytime available in any capacity to help you out in anything, anywhere. Thank you.
Absolutely. We are really grateful, ma'am. Absolutely wonderful. Thank you.
Definitely, ma'am. I'm sure our speakers and definitely our co-chair of the Health Committee, Dr. Samir Gupta, whose brainchild was this particular
Oh, wonderful.
conduct a webinar like this. So I must give all the due credit to Dr. Samir Gupta, for taking this initiative. And I'm
Wonderful.
sure that, going forward, we would love to collaborate with the government as an industry across the spectrum, as a chamber, as hospitals, as healthcare providers, as aged care providers, and much more. And I think one thing which I really liked about was the talk about Ayush, which you did, how we can actually integrate that. Actually, our senior vice president had to leave, but he is a torchbearer of the Ayush industry. He's been there for 80 years. So I think.
Well, his ancestors, I would say, along with him. He's not 80 years old as yet, but his elder generations were there.
I stand corrected, President. So I'm sure, ma'am, we will be able to work with you in a lot more areas, including IEC, as our president suggested, that we should talk about it more, let people know about it a lot more. And we'll be glad to hear your comments after all the speakers have also spoken, so that we can identify areas how we can take it forward beyond this. I would say even a fraction of a drop of an ocean, which we have started today. So with the permission of the president, I'd like to invite Dr. Prasoon Chatterjee. I think I'll have to make that change. My apologies to Ms. Shalini Mathur, as well as I think other speakers, because Dr. Prasoon Chatterjee has to leave for a meeting. So with your permission, Ms. Shalini Mathur, may I request Dr. Prasoon Chatterjee? So kind of you, ma'am. Dr. Prasoon Chatterjee, Associate Professor, Department of Geriatric Medicine at AIIMS, one of the most acknowledged and respected institution for healthcare, and also a consultant for WHO Regional Office for Southeast Asia. Over to you, Dr. Prasoon. It would be lovely listening to you.
Thank you to the organizing committee, PHDCC president, all the esteemed guests, and the audience. I'm sorry, there is some technical glitch. So because I'm on the way towards my next meeting, so I'll just opportunity. But I think after Dr. Gauri spoke, I I don't have much to say. I can only create some some idea which we need to introspect. If I am an elderly person who is 60 plus, 70 plus, 80 plus, I have to prepare for healthy aging, which the whole going on repeatedly. Because responsibility goes to everyone. It's not alone the policymaker, the hospital, the family member. So first starts with the individual himself, and preparation for healthy aging is a life course. Like the day a baby born, he or she started aging. So even middle-aged people, they have to think how they can create a graceful aging in their late life. So we have to consider that. So starting off healthy aging, preparation for healthy aging, preparation for active aging started much earlier, even in middle life, because multiple studies have shown that middle life, how I am behaving, how am I behaving will predict whether I will develop dementia, whether I'll develop stroke or any other disease. So to my beloved senior citizen, I'd request that prepare for active and graceful aging, which is possible. You may live and die like Dr. Kalam, who was again from a very, very poor family. We always starts with economic status and all these things. So you can be intellectually superior and active, like super ager. I'm studying on it, super ager. You can be like that, just like Dr. Kalam. You can live a healthy life like Mr. Milkha Singh, who just recently expired. it is possible to live so physically and mentally healthy. But of course, you need a purpose in your life. You have to have purpose like our honorable prime minister or our honorable president of India. So you have to have a purpose which differentiate between an elderly person who is going for frailty and dementia every day and night, as compared to anybody like as I mentioned. If I am in my 40s and 50s, I am taking care of my parents like me. I have to support him because I understand if my parents are healthy and hearty and joyful, they give lot of grace to the family, and it is really helpful for me. Instead of taking care of ailing parents day in and day out, I'm going to hospital, coming back. Instead, I need a parents who are healthy, who are happy, who are still active. So I should promote active aging for my parents. If I am a children of like just like my child who is around 10, I would prefer to have a grandparents who is active and healthy, who is ready to mingle with me, who is ready to go and visit park, who is ready to go some entertainment. So like that. So every generation has to consider that how important is this to be active and healthy, for healthy elderly generation. And anyway, today or tomorrow, everybody will reach that phase. If I talk about demography in 2050, the population in absolute number, the children and young generation will be equal to elderly people. So मैं स्कूल में जाके यही बोलता हूँ, आज अगर आप अपने दादा दादी के केयर नहीं कर रहे हो, who will take care of you the day in 2050 most of the children will be elderly, right? So the preparation has to be from all sector, and let's start with yourself. That is again the same thing what Gandhiji spoke, that be the change. So first the elderly person himself has to think, and he has to change his attitude towards aging. That is most important. Then lastly, I would say definitely uh, COVID crisis. In one way, it has created a lot of opportunity, as Dr. Gauri mentioned, but for elderly, it is not so great that way. I will say, because social isolation, loneliness, ageism, elder abuse has increased drastically. They will be much more vulnerable. And once you remember, once someone is vulnerable, the chances of elder abuse is maximum. So you may be vulnerable for economically, you may be vulnerable physically, you may be vulnerable mentally. So everything actually has happened. I will not go in detail due to lack of time. Everything has happened during COVID crisis, and this will ultimately create humongous problem on healthcare system, because all these are precipitant of dementia, which is one of the most difficult expression of aging. So we have to prepare ourselves. Rather, God forbid it should not happen. We have to prepare ourselves to prevent dementia pandemic. Unlike COVID pandemic, which will go in 1 year or 2 years, dementia pandemic is going to be decades after decades. So that we can prevent only through active and healthy aging. So I think in a nutshell, I have mentioned whatever, and in my discussion itself, I mentioned this solution is preparation from all sector. I need not to mention every sector, and definitely private sector has to take part. And through this forum, I would request Madam also how GOI can be connected actually with private sector. That we have to find out, because there many times it's very difficult. Like private sector means only they want to earn money. Private sector NGOs, that is not the case. We have to work together. That is very important. So thanks for the opportunity, and I'm sorry I have to leave the meeting after this. Yeah.
Thank you, sir. Wonderful.
Thank you, Dr. Prasoon. Yes, I think all sectors have to actively participate, and we can rest assure you that the two foundations which the PhD Chamber runs for more than 35 years, the PhD Rural Development Foundation and the PhD Family Welfare Foundation. Actually, it started much before CSR became a buzzword and also a part of the balance sheet of the corporates, has been doing some commendable work, and our members, along with these foundations, will work hand in hand with AIMS and DGHS office to take it forward. With this, I'd like to invite none other but the Chief Advisor from Aurum Senior and Assistant Living, Mr. Sanjay Prasrichaji. Sir, we have a lot to know from you as to how it is evolving back at Aurum in India, and how do you see it, so that then we can actually go down and get an international perspective and see how we can actually shape it for the elder care in our country. Over to you, Mr. Basri.
Thank you, Vivekji. Thank you, everybody, for giving me and giving us this opportunity. Respective panelists, Dr. Gauri, your presentation was just fantastic and tells us how we really undermine what is being done by the establishment, really, partially because we are so unaware about whatever is being done. And somebody did mention rightly that perhaps we need to broadcast it and publicize it a lot more as to what is happening and at the government level. Specifically, I think a lot has been spoken about the size of the market. And I am coming wearing the hat of a private entrepreneur. I'm representing private industry out here to tell you that there is a lot that needs to be done on the private public partnership platform. There is no doubt. And as in the next few minutes, you'll understand what is the opportunities that lie there. Because one, there is a planning paper which is presented. There is a lot that the government does. But unless the private sector participates with the government, we cannot see this moving forward. The market has exploded, and in the decades to come will explode further. Whether it's 8% of the population rising to 10% of the population, going to 12.5% of the population, the numbers jumping up from 100 million to currently 140 million and going up to 320 million are huge numbers. We also know that in India, there is a huge divide between the rural part of India and the urban part. And my view is strongly that how you handle aging from the rural part and how you handle aging for the urban part has to be two different things. The problems have to be handled in a different way. And me personally, I will be focusing more on the urban part. Aging, obviously, the numbers have also gone up because the age expectancies have gone up. The life expectancy, which was at about 43 years in 1960, has been steadily rising and is currently at 70 years. So the number of people who are in this age group of 60 years to 90 years, which require care, are all the people in today's day and age are people who were born between 1930 and 1960. A lot of us, and I'm saying us because I happen to be in a part of that age group, are able to really identify and table what is the change that this generation has gone through. The people who were born between 1930 and between 1960 have really experienced change like no other generation. So to go to the old age adage that change is the only constant in life is actually true, because we've actually experienced change. Change in technology, change in lifestyles, change in medicine, change in education, change in the houses that we live, change seeing our own children grow up, the way we treated our parents or our grandparents, and the way they treat us. The pressures on time are very heavy with our generation next. Our generation next is no longer in any assignment or job, which is a 9-to-5 job. Yet when we look back, we found that our parents were coming back from their offices, from their work schedules, reaching home by 6. Today, it's a 24/7 working schedule. We expect so much from the next generation to say, yes, it is they who need to, Dr. Prashant said, we need to look after our grandparents. But do we have the bandwidth? Is there really time when 24/7 is going away in professions? There is no mental time free for the generation next to really look. They understand that their parents, their grandchildren need help. But are they able to give you that help? Because that one room which was free has now become an office room for work from home. Where is the older person who's 60 and 70 in the house going to be able to relax? What is the main crisis that is facing the older generation today? The older generation is faced with the major crisis of boredom. He's faced with where does he interact with people of his age? We turn around and say, yes, we are looking after him. My grandfather or my father is getting his meal on time. A doctor is being called to him. But is that what he wants? Why is the doctor required in the first place? Why is the meal, why do we look at just giving him a meal and not the kind of meal that he really requires? The change that has taken place is the meal that is required in the house for a teenager or a person who's 40 years old may not be the kind of meal or the nutrition that is required for the 70-year-old in the house. So by just accepting the fact that we are mentally, yes, we want to do it, we must actually create that inbuilt analysis for people to say, you have the good desire to do it, but are you really able to do it in a qualitative manner? This is the age of specialization. And that's exactly where I feel that private sector comes in to handle the issue of boredom, to handle the issue that is really required of looking after a person for his medical needs, looking after the physical change needs that are required by an elder person. Handling emergencies is a great need that is there, or being able to ensure that the elder person is not abused, neglected through isolation. A very simple example of isolation is I have my friends coming, I'm 50 years old, I have my friends coming across. We feel that we are wanting to involve our parents or our grandparents. We call them in, introduce them to our parent. But don't we realize that after 15 minutes, the parent is left or the grandparent has left the room and gone away? So are we really doing our job? I'm wanting to raise the conscious level that in this day and age of specialization, we must also change the mindset of our 45, 50-year-olds. Today, staying at home, we are actually being very possessive about the fact that we want to keep our parents and our grandparents at home. But really, is that where they want to stay? Won't they be happier staying in a community environment where there are other people who are their ages, where they can discuss topics of their concern? Why are we always concerned that I as a 50-year-old might want them with me? What is it that they want? So we say, no, we will look after our parents, because if I don't say that, what will my friends, my relatives, or his relatives talk about it, saying, what have they done? So we need to open up society's mind to the fact that no longer will, like 20 years ago when we used to travel on business, we used to stay with our mama and chacha. Today, who the hell thinks of staying with a relative on business? Similarly, as parents, as our known friends' parents grow older, we need to be open in our minds to saying private enterprise is setting up great homes. Retirement homes are not old age homes. Retirement homes are residences. It's changing a residence from your own residence of where your son or your daughter or your relatives are staying to staying with people who you will be able to interact with more. It's not just adding years to life. It is adding life to years. What's the point of living to your 80s and 90s? 5 days ago, there is somebody in my family who expired. She was 85 years old. But it was the one thing that people said was, oh, she died in her sleep. It was a nice way to go. She was leading a happy life. She wasn't suffering. Happiness comes in happiness of the mind, not only happiness of the physique. The physical, the emotional mind is what you need to do. Having studied all these needs, I came in from the hospitality industry. And so one is able to relate a lot of what the hospitality industry went through as a growth phase to what the health industry needs to creating retirement homes, retirement residences for people who are able to create it. And this does not only need to be created at the premium level. This can be created at levels like hotels are there of 3, 4, and 5 star. You can create residences which are there at various affordability levels. So what is the biggest barrier coming in? Like hospitality faced this huge barrier, that land cost was the biggest barrier. So in the beginning, only 5-star hotels, still about 5, 7, 10 years ago, we found that hotels in India were only 5-star because that's the only way they would break even. Private enterprise is not going to come in to make losses. That is the bitter truth. At least they will want to have a margin of return, which is slightly higher than when they keep the money in the bank. So I think establishment needs to look and hear the private people to ask them, what is it that they require? At Aurum, we've created 40 rooms, but we've allocated 1,000 square feet per room. They're all studio apartments. Yes, we are hitting out at the premium sector there. But why are we hitting out of the premium sector? Because there's a cost of land, there is a cost of capital, there is taxation, there is manpower. There's a cost of manpower. To employ a general manager for a facility of 40 hotels requires, we employ a chef, you employ a front office person, you employ housekeeping persons to maintain it. Because today people's houses are maintained in a spick and span manner. Now, people also want to move out today whose children have moved out. More and more children have moved out into United States, UK, Australia, Germany in the last 10 years than it perhaps in the previous 30 years. All those people are staying alone. Isn't there a danger for them as far as emergency is concerned if they're staying alone? So I think the role together with the government, private sector needs to launch a huge social awareness campaign. A campaign not only of what the government is doing through its district level hospitals, which is a great job, I think, that is being done, but a social awareness campaign that what is a mind block for you. The way you look after your parents is not the way you want to look after, but the way they want to be looked after. Open up avenues to them and healthy aging will happen. People in their own minds will be emotionally stronger. At Aurum, we handle caring in under 4 platforms. There is a holistic care segment under which there is emotional care, there is physical care, there is spiritual care, there is intellectual care. When you handle it in a structured manner, no home or child will ever look upon it in a structured manner like this, to look after his parents. So my plea is that yes, involve public, involve the private sector in this industry, and not only in the creation of retirement homes and in retirement residences, but also in caring for people, in taking care for people to their houses, in creating daycare centers. These are all opportunities which are lying to be waiting to be used. But why is there very slow movement is something that we need to really give a thought to it. My plea on a couple of things which will help private industry come in is really issues like land prices, capital cost, the tax burden for the first 10 years, a tax-free state, helping in training institutes for skills development, which Ma'am Gauri had said very clearly. Geriatric care assistants need to be trained. I cannot take somebody who's not trained to look after a geriatric. And as this industry grows, like in many other service sectors, manpower and trained manpower is going to become a huge problem. We need to think about that right now. Otherwise, the decade of the healthy will remain in paper. It won't happen. You need to be able to provide a very simple thing like electricity cost at a residential rate and not at commercial rates. we need to have a quality control team under the government, under the Department of Geriatrics, perhaps, a whole quality control team which will go in and which will classify these old age homes under various segments, so that the segment of that care home will actually create the tariff barriers for various elements. We need to have a categorization body. We need to perhaps look at welfare programs, which the government is looking at. But more important is we need to dovetail insurance with this sector, because there has to be a way and means in which people at the younger age can insure themselves to be able to move into such community living and community houses in future by being looked after. So people who have comorbidities, or people who have dementia, or people who need assistive care, assistive care must come under insurance, whether it is home care or it is in residence houses. With the limited time I had, I've presented my case, and I leave it for PhD Chamber of Commerce and for Dr. Gauri to see how we can get together again in a smaller forum and take this forward. Thank you so much.
Thank you. Thank you so much, Mr. Pasricha. And I think presenting a perspective, it says add life to years as well. I think well taken and well understood. And I'm sure we are all listening and will see how we can actually take it forward. And definitely your views are most welcome, and we would like to study them and also discuss it with the government on joint areas of working on those specific asks which you had. So that's thank you very much, Mr. Pasricha, for your presentation. I think one important point which you touched upon was 24/7 working, youngsters not having time. Time for me to kind of not only invite Ms. Mathur, but also challenge her with this, that, this is a culture which we got all the way from West, technology, working 24/7. And you did it there much earlier than what we did or what we are doing. So and I think one good thing which has happened in today's session is you've got an overall perspective of what's happening in India, where the government is thinking, where the private players are, what are our views. So would you like to share with us your thoughts on, how we can go about it in the international way, of course, fine-tuned to our needs? Over to you, Ms. Mathur.
Thank you, Vivekji. This has been a wonderful session thus far, and I really am honored to be here. It has been so good to hear the initiatives that Dr. Gauri mentioned that are being taken by the government of India, and those taken, as mentioned by Mr. Pasricha, about through the private sector. And I'm really looking forward to seeing these pan out in the years ahead. A little bit about myself, Vivekji, just to kind of go back and tell you where I'm coming from. I grew up in India. I got my master's degree from Delhi University. Since then, I have lived and worked outside India in the US, Switzerland, and in Malaysia. I also am certified in gerontology, and I've been working specifically with seniors for the last 7 years. Presently, I work for the Department of Elder and Human Services for my town in Massachusetts. It's a government-run agency. I have also worked in privately owned and managed senior care facilities in New Jersey and Massachusetts. These have also included assisted living as well as memory care units. So you're right that we have started much earlier, and in that it has been a collaboration between the government and private sector completely. And I have been very fortunate that I've worked with the private industry as well as now I am with the government sector. So I hope I can bring some a different perspective. And I did start off by, I wanted to say that I did entitle my talk as Adding Life to Years, a US perspective, because that is our aim. We need to add life to years because we have, thanks to science and medicine, we have already added years to life. I would like to start here with a quote by an author, Dr. Gawande, which is very meaningful to me. And I quote, "It is not death that the very old tell me they fear. It is what happens short of death, losing their hearing, their memory, their best friends, their way of life." That to me is the starting point of understanding that aging is a natural process of life. Majority of older adults 65 and above are healthy, happy, independent, leading independent lives, and will continue to live that way until the very end of their lives. So it is really very important, as another speaker mentioned earlier, not to stereotype them. There are no stereotypes with older adults any longer. To make aging a natural part of life means managing needs that the older population will require while maintaining quality of life, staying active, and letting them age with dignity. Changes will happen. We know that physical, psychological, emotional, cognitive. Um, People have mentioned, specific activities of daily living, what you can do, what the ability physically to perform certain tasks, any disabilities that might come up. Cognitive issues happen. Dementia is a big thing. There are certain things that happen as part of normal aging, certain that are not part of normal aging. Now, from my experience, having worked in the US with seniors, there are options here that I've just kind of generalized into two boxes. One says living arrangements of how seniors live in the United States and the services they require and they're able to get here. For living arrangements, the concept of aging in place is a very well-known one in the United States. Seniors will continue to live in their own homes after retirement. And as needs change, the local, state, and federal government comes in with their sponsored programs, like they have programs like the Visiting Nurse Association, Meals on Wheels, which bring services to their homes as and when required. So that is the concept of aging in place. There is, of course, retirement communities that happen that are all over the country, 55 and adult, active adult communities, for example. Another thing which actually is something that I think we can implement, we can bring about in India also, is something called continuing care retirement communities. These are retirement communities with accommodations for independent living, assisted living, memory care unit, and in certain sections, they also have nursing home care. So a senior citizen, for example, could sell their home and then move into an independent home within that facility. And if the need for help arises, they move into the assisted living part of that facility, of that community, where they can have meals served in a dining room. A nurse can help with dispensing medicines. Member of that facility can help them with whatever needs they require. And if the need so arises that they need help with memory issues and they need to move into the memory care unit, they go into the unit which is available right there. So it becomes a continuum of care, and that is also a very popular, that is seen especially as family members, like Mr. Pasricha said. As family members, you worry about what's happening with your parents as they age. For family members, it is very reassuring that once mom and dad are in a particular place, that place will take care of them till the end of life, depending on the needs that they have. Within every facility, a very important change has come about where we're now talking about and we're implementing household models. These have been a great success story in the United States, especially for memory care neighborhoods. So the resident, for example, lives in a safe and secure, because memory care units are completely different. You want, when the need arises, family members want their loved ones to be in a safe and secure environment and be looked after with all possible facilities. So in a household model, the physical space is set up like a home, a dining room, a living room, a room to watch television, and their own bedrooms along a corridor on the side. All members are, expected to come out, go about their daily routines. help setting the table for meal times, help fold laundry, watch TV together, play games together, and so on, all within, safe and secure space. I'm talking about the memory care environment right now. In that neighborhood, you're in a safe environment, yet it is like your own household. So for somebody who is suffering from dementia, they are not in a nursing home kind of environment. It is more important to keep them in a place where they have lived and grown up all their lives. Moving on to services that are available here. Senior centers, which are government sponsored and government run places, are a great place for daily social gatherings, and also a great resource for information. For example, during COVID-19 times, the senior center that in the town that I work in, we organized vaccination clinics right there. We helped people make online appointments for vaccinations that they had to go to some other place. So the senior center not just acts as a place to gather for social events, but also information. Senior centers also have social and outreach services. We have a social worker, we have 2 outreach workers. So we make sure that, people, any need that the older adults have in our community, we can take care of them. We provide transportation for medical appointments, shopping, hairdressing appointments, and so on. Daily lunches at a nominal cost. You can, book a lunch ahead. So it's like a community center, a daycare center, but it's a little more than that, because not only are we providing services, of course, we're also providing, exercise classes, fitness classes, lots of programming, educational lectures, card games, bingo, housey. So popular among this age group that they love getting together. And, again, the whole idea is socialization, making sure they're active and engaged. We have at my senior center and also at the private facilities where I've worked before, clubs like the book club, knitting club, gardening, walking, popular means of socialization, dance programs. Believe it or not, we have such an active participation for our Zumba classes, line dancing classes. It is amazing. We think being on this side, often, we think about 65 and above, retired, and that's it. You've given up everything. You have not. That is the time to enjoy, to make sure that you continue all the interests that you've had all through your life. I'd like to touch upon again, as Vivekji said, cultural context of India and the US. I have noticed here, I've seen it very clearly that the similarities are great. The families still remain main caregivers for as long as they are able to. Again, like you said, with 24/7, it does become difficult, which is when these continuum care facilities come in, assisted living facilities come into play, where you know that your parents are well taken care of, and you don't feel that burden of guilt or sense of responsibility that, and often it is based, it is to the detriment of the caregiver's own health and mental, physical health, that, they have to look after mom and dad, so much so after finishing their 9 to 5 or 9 to 8 jobs. Challenges are immense, of course. There are differences between the two. We are in the US a little ahead of the times of what India is going through now. But I think it's a great possibility to learn from our models here. More seniors do live independently here in the US. They live in their own homes for as long as they can. Again, social economic conditions, there is less stigma attached to to moving out, to parents moving out. In Eastern cultures, we still have some social stigma attached to oh, I'm not being able to look after my parent. What will people say? What will people say? Log kya kahenge? As I think Mr. Agarwal said earlier. It is also easier to ask for professional help in the United States. And again, the government of India is doing great things, initiatives that they have to make that happen, that you can go outside the family, outside your immediate social circle and ask for help. through medical professionals and so on. I want to share a couple of heartwarming stories, just from my experience, if I may. I know I'm taking up a little more time than my 5 minutes, but this I think it's a good thing to hear this. At one of the facilities where I worked, I introduced a program called Armchair Travel. I'm talking specifically about how it worked so successfully in the memory care neighborhood. I would show photographs of my travel to particular countries that I've been to or where I lived, and accompanied with a commentary that I would talk about, this particular place or what happened. That would lead to such amazing stories from the residents, and it was so heartening to see that memory, care residents would talk about their trips to the same place. They could remember with great clarity and accuracy even the meals that they had there, and it led to so much fun discussing later on. So that was definitely a success story. Another one was that I set up a knitting club at another facility, and one lady who lived in assisted living and would not leave her room for anything else except meals, we found out she was interested in knitting. She was an avid knitter. She started coming and joining this group that we created. We would meet in the common space for an hour every week. She would come share wonderful stories about her life. She would not talk to other people. She would just narrate. And it was just so good to see them, that see how she and the other group interacted together, the rest of the people in the group. She would knit 2 or 3 caps per week, which we were donating to a cancer organization, because that, again, a sense of purpose right there. The knitting club became the highlight of her week, and mine too, because I was excited to see what she would talk about this week. So those are just a few things that I wanted to touch upon. I'd like to end by sharing some of my learning. Firstly, we must recognize and accept changes that come in the lives of our older family and community members as they age. Secondly, we must recognize the strengths of older adults. It is important to remember that they have lived through a lifetime of unique experiences and have had unique skills, and they still might have those. Some of these skills are being lost to us in this century, in this age of technology. We're losing out on some skills. So that's an important thing to remember. Thirdly, we should, it has been stressed enough and can't be stressed more enough, is we should aim to give our seniors a sense of purpose, a reason to get up every morning, have a routine, a plan for the day. Perhaps they'll find new interests. Maybe they'll just continue the interests that they had. And a way to do this is to create support networks, families, friends, places where they can go to share their interests, talk to their own peers and not just to the younger generations. So they can stay connected, and again, most important, sense of purpose. And last but not least, give them the emotional support and encouragement that they need to continue to maintain a wonderful quality of life that allows them to age with dignity. I'd like to end with another quote. Our ultimate goal, after all, is not a good death, but a good life to the very end. Thank you.
That was wonderful, Ms. Mathur. I think combining your experience both with the State Department of Health at Massachusetts, as well as your private stint with the private industry, and of course, I think that's where we all started with Dr. Subramanian, or the president, or further reinforced by Dr. Gauri. The passion, I think, which has flown down through all the presentations so far, which we could see in what you could also talk about. It just germinates a thought process which I'd like to propose to Dr. Sen Gupta at this stage. I don't know if it's too early, but I think with so much of knowledge flowing and other things which we can think and talk and do about, it may be a good idea that the ministry might like to constitute a task force by inviting various stakeholders and try to see, where we can go forward with the next step beyond the wonderful work which you shared with us, which the ministry is doing, from the experiences of the Indian industry as well as the healthcare providers back in the US. We had Ms. Mathur there. So, I mean, maybe it's a bit too early, but just because it occurred to me, I thought I must mention it for other people, including our co-chairs, who could also throw some light on this. So, time for me to invite Dr. Samir Gupta. And as I said earlier, I think he's the man behind this webinar. And it's his thought process and his inspiring us to, do something like that, which has brought all of us together this evening. So, Dr. Samir Gupta, co-chair, Health Committee, PhD Chamber of Commerce and Industry, over to you.
Thank you so much, Vivek ji, for organizing. I would like to thank all the esteemed panelists who joined, our guest of honor, Dr. Sen Gupta. It's a pleasure to meet you. I've heard your name so much in the circles. You are the authority of geriatric care in the country, and we are glad to have you over here. And you shared everything and the great work that the government is doing, being spearheaded by you. I would like to, so I'll tell you a little bit about, a lot has already been spoken about where the future of geriatric care is, where we are headed. But I would like to just give you my personal context as to how this entire thing came about. It was not long back. I grew up with my parents in Delhi, and my grandparents would come and visit us very often. And then I moved to the US for education. I lived all over in New York, Chicago, and I was introduced. I remember the first day of residency when I was training, my senior resident told me, just make sure where your patient who is 75 going. I said, I couldn't comprehend completely. I said, but he's going to go home. He's like, no, and people in America don't always go home because they live by themselves. And it took me a little while to try and understand the entire concept when I was training, to understand about how aging happens, how when somebody is 60 is different from somebody who's 70, who's different from somebody who's 80, who's completely different than somebody who is 80 with who's healthy, is completely different from 65 who's got illnesses and diseases and comorbidities. It's a completely separate skill set of completely different physical ability of people. And then I was introduced to this entire concept of aging, of gerontology, of geriatrics, of care homes, of home care, because about 20 years ago or 15 years ago, these things were kind of non-existent in India. They didn't exist. This was a new concept, and it took me a long time. I'm like, why is this person not going home? Why can't his family members take care of him? And I initially thought this was a concept which was exclusively for the Western population. Then when I moved back to India, and I remember I was completely taken aback because everything had changed. Like Mr. Procedure had rightfully said, the younger people are busy in their work. They don't have that much time to spend with the grandparents or the parents. The longevity of people has increased. The longevity of people 20 years or 30 years ago was maybe 60. Now that longevity is 70. And a large percentage of our country population is now going upwards of 80. Those people who are keeping themselves healthy and can afford good health care. So the concept, so the way things have changed in the demographic, in the socioeconomic status of people, the availability, the accessibility, and the knowledge, with the internet, now everybody understands all these things. So this entire concept has changed. And that has led to why I was kind of thinking about doing something like this. Now, there are still a lot of challenges that we face in India. A lack of physical infrastructure. This is a really big deterrent. And purpose-driven care homes. And even not just purpose-driven care homes. When you go outside and you see, many of my patients live on the 3rd floor, 4th floor of DDA flats. When these flats were built, they didn't have elevators. And it is a mammoth task for these people to go for medical emergencies. And even I'm a cardiologist coming and seeing me in the OPD. They're like, doc, I have to climb down 3 flights of stairs.
and then I have to come and see you. It is just a mammoth task for me. It is like that day when I come out to see you, I finish all my errands. I go to the market, I go buy my vegetables, I do everything that day because that's the day I'm going to go down and climb those stairs. Public areas having wheelchairs and reduce that ramp, keeping a ramp in public areas, even in our government institutions. If somebody wants to go to the museum, or if you want to go to the zoo or anywhere else, you should have public ramps. You should have the ability that a disabled person, whether it be a younger person who's disabled or an older person who needs a wheelchair or you wants to use his walker, can easily go. So these are small things in physical infrastructure that is required. There are a lot of other, then obviously we've talked about the financial support that is required by the elderly. The elderly, now when you go to the US, they have a very strong, and Shalini ji can obviously talk more about it, but they have a very strong social security system where you buy into the social security system. Your entire life, you put money in it in your working life. And then after you reach a certain age group, you draw back, you get this annual $2,000 or $3,000, depending upon how much you've put in. And that kind of gets you a safeguard. So that's very, very important. The other challenge people face is healthcare. Once again, healthcare, and I'm using the example of the Western countries, where in Europe or in the United States. In Europe, obviously the healthcare system in Europe is all public funded. So it's completely free. You can go in Canada, in France, in England, you just go and get your healthcare from the nearest hospital. In the United States, they have a system called Medicare, where after you hit a certain age, you get very good healthcare, which is almost free for you because you've paid for it your entire life. So that kind of system is also something very important, because this is a major challenge that the seniors face. They face challenges of health infrastructure, of physical infrastructure, of physical challenges, and also about financial support. We've talked about financial support. One more thing in financial support is the reverse mortgage. I know now in India, reverse mortgages are coming in. Some of the banks have started talking about it, but that is also something which needs to be publicized a little bit more, because your child, we always think about leaving things for our children, but what about you as you age, right? You work your entire life, not just for your children, but also for yourself. So the principle of reverse mortgage is also coming in now slowly and steadily in India. I was talking to a few bankers who were telling me the system is coming in. So that's also something which needs to be publicized a little bit more. And the elderly people need to be told about it. The seniors need to know that this thing exists. Also, I would like to say that the needs of the senior residents, they change as they age. Your requirement when you're 60 is very different from your requirement when you're 70. And this also changes with Dr. Gupta's post over there. She said that India is now the ageism, that as you age, your sex ratio gets skewed. So now there'll be more women, and if I remember the statistic correctly, it was 1,081 women for 1,000 men. And I remember looking at the statistic and said, this is the reverse of the sex ratio which was there when we were growing up, and you would see the infant as the birth rate sex ratio. This was a complete opposite of that. So now we will have a lot of older women who are traditionally not considered that strong to live independently out. They may or may not want to live with their children. The children may or may not be able to take care of for themselves, of the women. So it's important that we try and find a solution for that problem, because we know that problem is coming. We know that is coming. So these are some of the things that I would just like to highlight. I think a lot has already been talked about by Dr. Pope, by Dr. Gupta and Mr. Pasricha and some of the other the panelists before me. But these are just some thought points, and I look forward to seeing what the other panelists have to say. And thank you very much, Vivekji, for organizing this. And Dr. Sen Gupta, I can assure you that we will be in touch, and I'm sure we will collaborate in many more ventures.
Thank you, Dr. Sameer. I think it was very pertinent, though very small things, but yet very pertinent, which you picked up. And you know, it's a great learning for me personally also, hearing all of you, because like all of us, even I have aging parents back at home. So a lot of things, you know, you can relate to, and some of the things make your eyes shine, you know, because when you uh, hear this and you're able to relate to it, you know, I think it sends some goose pimples down your spine. Um, Thank you very much for sensitizing all of us this evening on those smaller points, yet very pertinent. I'd like to now invite Dr. Sonia Lal Gupta, our senior consultant neurologist from Metro Group of Hospitals. I think we've talked a lot in the evening, during the evening, on neurologic related to it. It'll be good to have your take on it, Dr. Sonia. Over to you.
Thank you so much, Vivek, for having me, and thank you so much for having me in general. It's such an honor to be with such an esteemed panel. And it's been absolutely wonderful listening to everyone. And it's actually, you know, wonderful to know that we are trying to at least now speak about elderly care. We're trying to speak about, you know, people getting older, because somehow and I feel in India it's always been kind of somewhere a taboo. Boode ho gaye hain, you know, that thing, wo to boode ho gaye hain, satya gaye hain, these kind of terms that have always been used. It's very sad, and that is not how it should, elderly care should be looked upon. And you know, Dr. Gauri Gupta, amazing to know about the program. I mean, you are right. I think the biggest problem is that we do not know about it. I mean, being a neurologist practicing in India, I really did not know about the program, and you know, extensively through you I got to know. And I'm like, the government is doing so much, we are just not aware. And I think I agree with what others said. We have to increase the awareness, because I'm sure people like me, you know, who are practicing actively would want to contribute in whatever way we can, you know, because this is something we see every day. And in our field, elders, you know, something so great. So thank you so much for bringing that forward and bringing awareness on that. You know, all our panelists have spoken a lot on the social aspects of elderly care and what are the problems we face. From a clinical standpoint, I wouldn't take a lot of time. I know we have a little less time, but you know, from a clinical standpoint, I think the key thing what I wanted to just kind of talk about was that yes, we have to actually understand that the elderly care population is now increasing. You know, and even the World Federation of Neurology has predicted that by 2050, approximately 2 billion people, or 21% of our world population, will be senior people. And it is high time we start recognizing the problems that they are facing, you know. And as a neurologist, when I'm practicing, when I see people, the biggest, I think, thing is for the family members. It is not the person itself. It is not the person who is aging, who is sometimes frustrated, but it is their family members who are more concerned and who are more like, who are frustrated that they do not know what is happening. So I think it is very important not to only bring awareness in the people who are suffering, but also their family members, and the early recognition of any neurological issue, especially when we come to elderlies. Neurological issues are very common, and the most common, I'm sure we all have heard of, is Alzheimer's dementia. We all have heard of Parkinson's disease. You know, we have all have heard of stroke. So these are the more common problems we see. But what is important is to bring awareness on how to recognize these issues. You know, sometimes people come in and say, you know, I'm starting to get memory problems, I'm starting to get forgetful, or a family member will say, you know, the behavior has changed of a person. The key from a clinical standpoint is to actually bring that awareness, to recognize these things early, so that non-pharmacological things can be set up. You know, Dr. Gauri, you know, you brought up a very important point of polypharmacy, which is actually a very big problem. You know, the solution is not that somebody walks in and you give a tablet. There is actually not much sometimes we can do in terms of problems like dementia. You know, when it comes to dementia, honestly, the medications we have, this very seldom work, and they very slowly, and they work at a point where, you know, the research is like, it may slow down a little bit of your cognitive decline, but there is no short way. So what is the way? It is actually focusing on the non-pharmacological ways, the multidisciplinary approach, you know, working on improving quality of life and healthy aging, looking at the diet, looking at their exercise, looking at the social interactions, and confirming and making activities that they can actually improve on that basis. And that can only be done when there is early recognition and things are started early on. A lot of times people come in when it's very late, and we see that the shrinkage of the brain, which happens in dementia, has already happened. And there's not much in terms that we can do clinically. And then there's, although we can still, but there's still a lot we can do from a non-pharmacological standpoint, what we can do in terms of activities and improving quality of life. But if the later they come in, the more less are the chances of seeing that improvement as a family member you want to see. It is very frustrating for a family member to see their elderly, to see their loved one actually go through a process like dementia or something like Parkinson's. Parkinson's, more than the medications, it is actually the exercise. It is practicing yoga, tai chi, chair exercises, which actually work more than the medications itself when practiced regularly. Exercise can do wonders for Parkinson's, but not many people know about it. So I think bringing awareness on these things are extremely important from a clinical perspective. So I think doctors need to come forward and say, what, yes, medicine is the route, but medicine is an adjunct to other things when it comes to elderly care. Same thing when we look at stroke, there's so many other chronic disorders that actually lead to stroke, like the risk factors like diabetes, high blood pressure, kidney disease, everything. We can say everything actually increases your risk of stroke. So again, managing that properly, but at the same time focusing on healthy living, I think is going to be key as we move forward. And I think when such programs are in place, it not only brings awareness to the people around, it will help the elderly, it will help the family members understand. So I think a lot of these daycare programs are very important. Some of the programs that Ms. Shalini Mathur actually, highlighted that they're doing in the US, they might seem like simple things, but they go a long way when it comes to the elderly. So I think from a clinical perspective, I would say it is important for everybody to recognize when you see small, subtle changes. And by subtle, I mean, it could be small changes like chabi bhulna nahi, but something like the person typically had a routine of doing something. Somebody who was very good in calculations, all of a sudden you're noticing they're not as crisp. Keep an eye, notice that. Somebody who was a very cheerful person, now the personality has changed. They're a little bit more dull, they're a little bit more depressed. They're not as social as they used to be. That could be the starting of a problem. So those subtle signs, a small little tremor that sometimes they feel and they get conscious when they're holding their cup of tea, that could be a sign that they're starting to get, they're having a new symptom. And sometimes the person itself, they don't notice it. Because honestly, poor realization and acceptance is also a problem. Believe me, it's very difficult for a 70-year-old to accept when they've lived an amazing life, where they've been independent, to finally reach a point and say, what, I might have a health issue, I might have a neurological problem, and I need to get help. It's very easy to say that, yes, aapko ji Parkinson's hai or you have dementia, but it's a very difficult thing to accept and to actually get help. Many a times people say, nee, I'm fine, I'm absolutely fine, mujhe help nahi chahiye. So I think bringing that awareness that it's normal, it's okay, let's recognize this. And then I think it's important from a clinical perspective where doctors come forward and actually start doing, joining hands with everybody else as well, so everybody can work as a team. The only way I personally feel that elderly care can actually improve further is through a multidisciplinary approach. And I think when we all work together towards that, we will definitely see a better healthy aging and a better quality of life in our seniors. So, it's been absolutely wonderful. I don't want to take a lot of time. I know it's been 2.5 hours at this point, but I would love to come back again if you ever want to, discuss more on the clinical aspect, because each topic is a topic in itself. But thank you so much again, Vivekji, for having me. It's been absolutely wonderful listening to everyone. And I really hope we continue doing such topics as well. I think it really helps bring awareness, on such an important aspect of what India is now going to be facing as we move forward. Thank you. Thank you so much.
Thank you. Thank you so much, Dr. Sonia Gupta. I think wonderful listening to you. Passion still flowing even after 2.5 hours, I guess, with the speakers. And you know, if we don't get inspired to do more, I'm sure Dr. Sengupta will make sure that she pushes us to do much more than that. And we would love that pushing, frankly, if you ask me. I'd just like to give in a moment to Dr. Grewal in case he'd like to say something, because you had an excellent presentation and kick-started it. And, would you like to say something more than what you had in your presentation? I'm sure. Over to you, please.
Thank you. It was nice hearing the experts speak. My only reaction is that Dr. Sengupta has been an old hand, and everywhere she's going, she's telling everybody, please do it, please do it. My only suggestion, very strong, which Samir has taken up, I must congratulate him. Let this not be a one-day event. See, everything happens, and I may be a little harsh, but whenever I have attended such meetings by other organizations, most of the panelists always say, wow, so much ho raha hai. Wow, this is what is happening. I have parents. And the next day they all forget about it. So I think, Samir, it's important that you've taken it up. I'm so glad you've taken it up. Now keep it sustained. You have the government with you. I'm with you, and you have the organization with you. Decide on a particular task for a certain period. Put it down. There is so much to do. But if you start doing everything, you'll get lost.
Yeah.
So identify one task, give it a time, you may not reach fully to that, reach to a certain level and then go to the next. So my only request to Vivek, let PhD design a program with one of the verticals. My suggestion is don't try and take up everything. Discuss again on the various verticals that Dr. Sengupta has mentioned. Try and pick up one which you people can do and take that up. Then you can switch on. That's all I want to say. Now that you've started it, don't stop it.
Yeah, absolutely. Thank you, Dr. Grewal. I think this is a great point, and this is certainly something we have been talking about of doing. And with your support,
you can, and if you people have succeeded holding Dr. Sengupta for so long, now don't leave her.
No. Now
She has already raised her hand, you know, and yes, Dr. Sengupta, we look forward to your comments and remarks.
Thank you so much. Dr. Grewal has always been a friend, philosopher, guide, and he has always been very to the point. So, first of all, I must congratulate. It was a pleasure hearing Dr. Samir. Wonderful points. Again, I reiterate what Dr. Grewal has said. My submission would be that why doesn't PHDCC come up with a white paper or a background note or a concept note or whatever? In that, at least, like we all highlighted and we decided that it has to be a multi-sectoral, all stakeholders, everything, whatever English word you may use, it is not possible for one sector to deal with it, because aging is not the baby of one sector, only health sector or only private or only public or only urban sector or whatever. It's just not possible. So I wouldn't say just one vertical. What I gave is just a kind of a brief synopsis of few things which I feel are like kind of pertinent right now. But I would love if PHDCC, with all the kind of resources you have, GUI is very poor in resources, both HR and finances for elder care. I didn't purposefully present the financials but you will be amazed at the allocation that is there to geriatric care amongst the total allocation, even amongst non-communicable diseases. So let's not harp on what is wrong and what is not wrong. Like I said, I always look for opportunities, and this is one of the best opportunities. Wonderful points. One thing which I wanted, with Dr. Sameer's, this things I got was, like you said, about age friendly advocacy. We've been giving age friendly advocacy to every Tom, Dick, and Harry except for the public health engineers or the civil engineers. And like one person had put it in this, that it should be a part of the curriculum. Does any engineering curriculum of civil engineering or anything have anything to do with how to develop age friendly or disabled friendly places? I think that's where we need to catch them, so that a person, whether he is in DDA or whether he is with Hafiz contractor, he develops something which is like kind of, it is age friendly, irrespective of whether it is a condominium or whether it is a public park or whatever. So that is just one of the things that I was thinking of. And one thing, like President Sir had said, that awareness. We are all focused on awareness to everybody, 40 plus, children for intergenerational bonding, and women and caregivers and healthcare workers. What about the elderly themselves? Why is it that none of us, I'm sure even amongst our parents and relatives, 60 plus, nobody bothers to even create their own will? They don't bother to, like, why is it that I'm, like, kind of giving my property in lieu of the care that I'm expecting from my children? Lovely examples by Mr. Pasricha of all the things that is available. But tell me, how many elderly are mentally making up their mind to actually adopt the technologies and try and live that life? That mindset may come to us, but till the time the elderly don't do it, the biggest point in force is that you have a lot of facilities which are available, but till the time the care seeking behavior is not going to increase, there is no point in us. It's like the family welfare part. I'm going to give all the basket choices of contraceptives, but it is the persons who have to use it who have to be actually aware. So I think we need to also focus on elderly to take care of themselves till the time they can, and then afterwards be prepared, be aware of everything that is available to them. They need to start making the decisions and not be dependent on my bahu or beta to take me for a spectacle correction or whatever. I don't think, like, all those examples that Ms. Shalini said and Sameer said, all this will come only through a change of mindset in the elderly, along with the other less than 60-year age population. So that is, like, we could have focused, targeted uh, awareness campaigns, advocacy campaigns, and all those kinds of things, reverse mortgage and all. So what I would really suggest is, why don't we come out with a white paper or a background note or a concept paper or a plan of action, which could be a concerted effort for the whole 10 years, and kind of put in place, like Dr. Grewal said, maybe the first 3 years, the next 3 years, and the next 3 years, different verticals to focus on, different sectors to be incorporated, and small things which can be done. But definitely, you need to put in reams of paper highlighting the wonderful practices, models which are already there in the private sector. That is something which needs to come out. Like, I'm doing the torch bearing for GUI. I think PHDCCI needs to do the torch bearing for uh, the private sector geriatric care initiatives that have been taken maybe in the last 10 years, because before that I can't think of anything that has been done in geriatric care.
I think our health committee is going to do that, ma'am. They are
Yeah.
very serious about it.
Yeah.
It's
So
very
I think
visible
that
to
will
us.
be good.
Right.
Right. Thank you, Dr. Sen Gupta. And it's I must tell you specifically, it's very rare that we have the president sitting through a webinar, and that too as long as 2.5 hours. So thank you very much, President, for your being there, because it really encourages and motivates us and inspires us, to do a lot more, on the ground.
It was a very interesting subject, and there's a lot to be done also. So
Right,
I
President.
think I had to be there.
So kind of you.
Thank you,
I
Sanjay.
think I'm going to.
Thank you, Sanjay ji. That means a lot. Thank you for being
My
here.
pleasure. My pleasure. Absolutely.
So I'm going to request our co-chair, Professor Harvinder Popli, the co-chair for the PhD's Health Committee, to do a tough task, as I said, of summing up today's discussion, because there's so much of information which has flown and throughout the evening for 2.5 hours. Over to you, ma'am.
Thank you, Vivekji. And you have rightly said that it's a very difficult task to summit. So I will not attempt to do summit, but I'll just attempt to say that the learnings, the immense learning, what we all had. And thank you, President, for also staying and motivating the entire health committee. And I must say that it is really Dr. Grewal who has started, initiated, and also given that we should not leave it in between. So investing in healthy aging means creating a future, what we have learned from all the panelists, and that gives older people the freedom to live lives that previous generations could never achieve. So we have to work towards it. So population aging is what we have learned, what president said. Then Dr. Subra told about that there was visual disability, hearing disability. We talked about Alzheimer, the Parkinson's, speech disability, locomotors, which we require also the psychologist help also. So this is happening much more quickly than in past. So India is come under the aging nations, and people are living longer. So we talked about 60 years plus 20 years. So how these 20 years are spent, it depends on your health. So health in older age is also a random, and very well told by Mr. Sanjoy Pasrija that we have to differentiate between urban and also the rural area. So we talked about what makes us age differently is the genetic inheritance and the lifetime where we live, who we are, our health behavior, and also to access to health. So there are a lot of things we discussed today. And we also discussed today also about the problems which is faced by the senior citizens. We talked about physical infrastructure and knowledge of specific diseases, the lack of financial support. And I must congratulate that Dr. Gauri Sen Gupta, has spoken about the National Program for Healthcare of Elders. And frankly speaking, even I was not aware that there are 718 centers which are sanctioned and 584 are operational centers. And this decade is of the decade of healthy aging, 2020 to 2030. So that means we all learned about that why elder care, and we took it as ma'am you told us this, we should take it as an opportunity. So I think as a PhD CCI and as also on my personal account, and also on behalf of the other NGOs like Rotary, it is something like an opportunity we should be looking into in future about it. And also there is a lot of materials which Dr. Gauri Sen Gupta has mentioned about, that materials which is developed for elderly care. And as man you told that we should take one in this thing, probably in a PhD in collaboration with another organizations which the president and I would be, and Dr. Subra is also part of our Rotary Club. So I think it's a great opportunity, and I'm very motivated to take that as a kind of a skill, because we have a lot of young generations, and there are a lot of people who also need to be trained for a geriatric cares, like all the people working in their homes. They have to have, if these modules are available with the government, so you don't need to reinvest, and then probably we can use these models to train those people. And in fact, during pandemic, elderly not only feared for their lives, but also the stigma which is attached to the infections. And the biggest challenge we have seen during the COVID-19 is the access to healthcare. And I was looking into some of the data which says that 62% of the elderly suffering from chronic diseases we called as asthma, chronic multiple or polypharmacy, as many of the speakers or panelists talked about it. So we need to also take care of that particular. And one of the very interesting thing which Shalini Mathur and also Mr. Sanjay Pasrija brought about is that how private sector, we are not only talking about the healthcare or a nutrition of the elderly, but there are things like a boredom or interaction, or besides the medical need. So I was also, I'm part of an advisor for one of the startups, and I was very impressed that they have started something like Silver Genie. So this is a startup wherein what they have been trying to do is that most of these elderly, even after the 60 years or 65 years, especially in India, we don't have a health record. We don't have access to where my old prescription is, what medicine I am taking is, where are my x-rays and others. And when you are approaching the physicians, they need to know your history. So this Silver Genie is a startup. So they thought that instead of asking your son who might be staying abroad or their daughter, so this initiative it has been, it's very interesting. This Silver Genie startup is based in India. It is the most of their clients are from US and Canada, because their parents are living in India. So from there, they are taking care of them. And during pandemic also, we have seen that the children are staying abroad and they are taking care of their parents. They are ordering the food through the different apps, which has become a kind of a reality. So this kind of a services, which has been offered, so that at one consolidated place, they feel very kind, what we can call it as assisted. Secondly, I think ma'am has talked about the financial support with the GOI. And, it was very interesting that my daughter was doing an MBA, and, she has been given a project during her MBA. And she said that when I asked her, she said, Mom, they have asked me to, do a financials for one old age home in Canada, in Derbyshire. And, you have to, they always have to do that. And these are all accounts which they have to manage, they have to run professionally. And she said that she learned so much, that there are so many NGOs who are also working in India. And we do, and they are not a financial experts, that from where their revenue comes, from where they were going to spend. So that kind of assistance has also been required. And I think something touched upon by Dr. Sameer and also by that Mr. Sanjay Pasrija, that when you ask for a money, and we are also associated, as a part of a Rotary with the one association called Hope Ek Asha. So the Hope Ek Asha has a center, something, very modern in Greater Kailash one only, and who take care of Alzheimer patients. So they say that we cater to a society where, the children can afford that. But, when they are going for outside, somewhere in a daycare, they need their company, because specifically everybody's been working 24/7, so they don't have a time to talk to. They can take care of their nutrition, they can spend the money for them, but they cannot give that time. And probably they get a company like whatever games, board games or other games, or even discussions. So probably there is more need in the private sectors, who can work specifically on that. And I think I will not take much of a time, but the one thing which is very closer to my heart is the awareness. And awareness, again, in a different aspects of it, for a different segment from a children, and very well said by Dr. Gauri, is that even awareness to to oneself, like who had all been aging, like that, and when they can probably take care of their own health, take a charge, take their control, and can spend something. What has been happening, probably Shalini would say that is happening abroad, probably that need to be over here. So we can use a lot of youngsters. And since I am part of a university of a Delhi Pharmaceutical Research Science University, which is also government, and we do run a course of a public health. and we do, some kind of a research also, so we can, involve both the master scholars and some kind of a PhDs, who had been working in this kind of a area, get the stats, and then, segregate that, how do we have to, and we can use a lot of, Rotaract, can be a source. The PHDCCI can, form that along with the government, some materials, which can be done, and then, we can spearhead that message. So this is what, I think probably from our own sides we can do. It was very difficult, to summarize and the submissions, but, it was very, very interesting subject. And thanks to Dr. Sameer Gupta, who through that, I came to know that, you had been supporting Aurum. And since, being a co-chair and being a colleague also, we were not aware. So sometimes, these forums, gives the opportunity to learn about each other as well. So thank you so much. And thank you for, sharing the wonderful website, which I was also Googling it while, discussion has been going on. It is immense and a lot of material is there. And probably, we can do a lot. So thank you. Over to you, Vivekji.
Thank you. Thank you so much. I think it was a brilliant job, to be able to, summarize so much and absorb so much, Professor Popley. Thanks a ton. Thanks a ton. And I'm sure with the two co-chairs, Dr. Sameer Gupta and Professor Popley, and of course, under the guidance of Dr. Subramanian and our president, we will spearhead on this particular aspect. And allow me 1.5 minutes, because I will be totally unfair to not only the esteemed panelists, but also to the gracious audience, who has been sticking around for 2.5 hours, listening to this interesting discussion, if I don't propose a proper vote of thanks. So on behalf of PhD Chamber of Commerce and Industry, PHDCCI, I would like to thank our guest of honor, Dr. Gauri N. Sen Gupta, Assistant Director General, Geriatric Health, DGHS, Ministry of Health and Family Welfare from Government of India, for sparing her valuable, I would say, almost 3 hours and sharing her views with the industry towards senior care in India. I would also like to thank profusely our president, Mr. Sanjay Agarwal, not only for his presidential remarks and is inspiring us, but also, staying back and listening to the discussions and giving a finality to what the chamber can contribute. I'd also like to thank our esteemed speakers of the session, Ms. Shalini Mathur, Department of Elder Affairs from Government of Massachusetts. Thank you so much for rising so early for us and staying awake in the wee hours with us and contributing so much to our discussion. Dr. Prasoon Chatterjee, who could probably stay with us only till such time, Associate Professor from the Department of Geriatric Medicine at AIIMS, New Delhi, and consultant for WHO Regional Office for Southeast Asia. Wonderful Dr. G.S. Gerewal, Editor-in-Chief of Voice of Elders, and a Senior Consultant Elder, Elder Care at the Fortis Escort Hospital in Okla. Dr. Sonia Lal Gupta, Senior Consultant Neurologist, Metro Group of Hospitals. Thank you so much. I think you brought in some very, very important points, which also ring a bell in my mind, what my parents are going through. So very, very, very pertinent things amongst the aging population. Mr. Sanjay Pasricha, Chief Advisor at Aurum Senior and Assisted Living. Fantastic points. I think you've laid down a path as to how the private industry can collaborate with the public healthcare system to, create these assisted living spaces. Of course, I'd like to thank Dr. Subramanian, the chair of the Health Committee, Dr. Sameer Gupta, and Professor Harvinder Popley for being here and guiding us. And I'm sure we will take it forward with all your guidance and support. I'd like to thank Aurum Senior and Assisted Living for sponsoring the webinar. And once again, let me thank all the guests and partners and speakers and the delegates for their patient listening. And I hope that not only the industry gains the knowledge, but also there was a lot of mutual learning which we went through today in the evening. My special thanks goes out to Dr. Ravi Rathore and Amit Patwal, who have been working tirelessly behind the scenes, the chamber, to make this happen. Thank you so much and have a good evening.
Thank you again, ma'am. We are really deeply honored by your presence and your participation. So enthusiastic, such an enthusiastic participation. Thank you.
Thank you. Thank you.
Thank you.
Thank you. Thank you.
Here, everyone. Thank you.